This is Dr. Ehtesham Khalid. I'm a neurologist and a neuromuscular subspecialist. And what I'm going to be talking today is a subgroup of patients who gets pregnant or plan on pregnancy with multiple sclerosis. This topic is very important. Why? Because it's complicated. It really takes some expertise to handle this particular patient population. The initial diagnosis is tough to make, but when it comes to the further management and fine-tuning of these patients is even harder. So let's start with my talk for today. So almost 40% of the females with MS, they either have mild disease, as Suhaib has mentioned. The good number of patients are diagnosed early on now. So they either have mild disease or they are not yet on the treatment and they get pregnant. But those who have mild disease, they don't have any exacerbation usually during pregnancy or in the postpartum period. And out of these MS population of patients, especially females, 33% of them become pregnant after the diagnosis of multiple sclerosis. So yes, it's hard to establish the diagnosis, but then comes the next step when they become pregnant, how to manage these patients. There are more than 15 disease-modifying therapies currently available in the market, which makes it better for the patient, harder for the physician, because then you have to juggle with those medications and try to find the right fit based on the patient personality and what they're gonna come across. Start with my case. She was a 30 years old female who presented with the pain in the left leg since September of 2020, which aggravated for the last 4 weeks and involved pain radiating from thighs to calves till toes, and it was causing her disability. So she was having difficulty walking, and when she lay down and rest, it gets better. The pain was of low intensity. She mainly calls it restlessness with generalized fatigue, warm feeling in the left foot, with no clear numbness or association with urinary incontinence. So you can understand how vague this patient was on presentation. She also had vertigo since 2015, and a lot of females, they complain about vertigo, many reasons for that. But additionally, she had blurring of vision and burning sensation of the right eye with dizziness. She also had one episode of left arm weakness, which was progressive, but it stayed. So even after 4 years, when she presented in our clinic, she was still weak in her left hand. So I think this was one big thing when you talk about a patient, young patient, having a lot of non-specific symptoms, but weak objectively on examination. So she was having finger abduction weakness of +4/5. There was some hyperreflexia on the left side. There was bilateral 2 beats of clonus in the lower extremities, but the rest of her examination was normal. And she had an MRI which was done in 2015, and there was a single lesion at C2, which was hyperintense. But there was no enhancement, no mention, no contrasted scan done. MRI brain showed some flare hyperintensities, and then she had MRI C-spine and T-spine with multiple lesions. I'm going to show you those. And after the clinic visit, we requested for vitamin D levels, and I'll tell you the significance for that. So out of the neurology residents, if somebody can tell me what's the name for these lesions. I don't have the pointer, so I can just point my finger. So what's the name for these lesions that we see in corpus callosum? Dawson fingers. And this is pretty much pathognomic for multiple sclerosis. What do you see here then? A couple of lesions if you see, and there is some contrast enhancement, okay? And there are 3 or 4 of them, but these are not in a long segment way, okay? Which actually changes your diagnosis. And Suhaib has rightly given you the McDonald's criteria. So this patient fits the criteria right away. So disease-modifying therapies, we need to remember what are the medications which are really important when it comes to pregnancy. So we should remember the medicines with the teratogenic potential because these are the worst ones. Teriflunomide and fingolimod are the two. There are medicines which can cause rebound relapses. Natalizumab and fingolimod are the one. And we need to know how to handle these medication when patient is on it and she plans on pregnancy. Then there are medications where their risk is low, but still there is a risk to the fetus. And dimethyl fumarate and alemtuzumab are the ones. We also need to understand what are the risk factors for any particular patient. So we decide if this patient is high-risk patient or a low-risk patient. So risk stratification is a very important part of management of multiple sclerosis. So if a patient is having a progressively worsening disease, if there is a sphincter involvement with or without motor involvement, if there is incomplete recovery from relapses, and if there are frequent relapses, that puts the patient high-risk patient. And out of the case we just discussed, what do you think is the reason I'm going to call my patient high risk? Anyone? Raise your hand so I can see the bright ones. So we just discussed the case, and patient had a risk factor putting her as a high risk. Yeah.
Partial recovery from the weakness.
Partial recovery. Very good one. Very good one. Nice job. So incomplete recovery from the relapse. So you can see there are modestly effective medicines, and then there are highly effective medicines. The red are the one which are most teratogenic, or the ones you really don't want to use in your patient. And the yellow ones are moderately fetal problematic medicines, and the green ones are the good ones. But most important thing that you need to know is if a patient gets pregnant, you need to stop all of these. And I'll talk about those, which one we can use in particular scenario. And this sheet, I used to use it as a backup when I used to make discussion with my patient, but this sheet is old now. So this is from 2019. So I'm going to talk about the recent stuff. So there are pre-pregnancy factors that we need to discuss whenever we have a patient in clinic and who's planned to get pregnant. So we have to make sure the patient is having active or uncontrolled disease or not, because that makes the patient high-risk patient. Hispanics and blacks, they have recurrent, frequent attacks and remaining disability. Poor obstetric or neurological care. So if the care is not appropriate, the patients tend to have poor prognosis when it comes to pregnancy. During pregnancy, these patients tend to have higher chances of infection. They tend to have hypertension and cardiovascular issues. There are increased chances of preeclampsia. There is mention of knotting of umbilical cord. So there are increased chances of preeclampsia and other medical problems in the mom. In the post-pregnancy time, there are increased chances of relapses, especially in the first 3 to 6 months, especially if a patient is having active disease pre-pregnancy time. So pregnancy in general is safe for multiple sclerosis patient. So somebody may ask me, and I will sure give an answer. So usually pregnancy patients, they tend to have less relapses unless they have a very highly active disease in the pre-pregnancy phase. Same goes for breastfeeding. So if a patient do exclusive breastfeeding, the chances of having a relapse is actually reduced. The fetal risk factors are that babies who are born to mothers who are using MS medication, they tend to have small size, so they're small for gestational age. There are chances of spontaneous abortions. There could be delayed ossification. There could be decreased fetal viability at the time of term, impaired learning and memory afterwards, and infant B-cell depletion, especially when it comes to monoclonal antibodies. So this chart is recently derived to guide the patients, because anytime a patient comes into the clinic and have a diagnosis of multiple sclerosis and it's a female, you have to discuss about the plan for pregnancy. If she's not planning to get pregnant, discuss about the contraception, okay, and other mood and behavior stuff. If a patient is planning for pregnancy, then you have to discuss about the fertility or conception issues. You have to discuss about the issues around the childbirth. Also, about the breastfeeding, coping with parenting, and social support should be assessed in these patients. And finally, most importantly, disease-modifying therapy. So pre-pregnancy management that I would really like the audience to understand and learn today. So these patients should be on prenatal vitamins. We say that, but how many times we discuss with our patients in the clinic, because that is the key. These patients should already be on vitamin D supplementation. And the recommendation varies from country to country, but even their vitamin D levels are normal. It should be good normal level, but they should be on vitamin D supplementation because that helps. If patient is a smoker, in Pakistan, few females are smoker, but still you need to discuss that part because it worsens the pregnancy outcome and worsens the disease. Assess for the anxiety and depression. We can do the screening questions and assess further during and in the postpartum period as well. Counseling about the contraception, family history, genetics is very important, and we need to discuss about where they are in terms of their disease severity. So what happens if a patient is planning to get pregnant, you have to switch these patients from hormonal to barrier contraception to give them time to have a normal ovulatory cycle. And also to reduce the time they're going to be off disease-modifying therapy. So that is a very key thing to discuss with the patients. If a patient, despite trying, hasn't been pregnant for 3 to 6 months, then she should be referred to fertility clinic, which is again different from normal population where you wait for 12 months. So these patients should be referred to fertility clinic early on. And the disease-modifying therapy adjustment based on the therapy patient is already on or based on the disease activity. But in general, we should wait for the 5 half-lives of the medication to give a washout time before patient actually stop contraception and try to get pregnant. And that half-life varies from drug to drug, but in general, for monoclonal antibodies, it varies from 20 to 25 days. And we need to make sure the disease is controlled in the pre-pregnancy phase. As we discussed, that will really help in terms of the pregnancy time and the postpartum time because the chances of relapse goes down. So recommendation is the disease should be controlled for a good 6 to 12 months of period of time before the patient gets pregnant. We also need to discuss about the genetic risk, and for the audience, there is almost more than 12 genes involved. There are almost 20% chances of the same family member in the same family to have multiple sclerosis. And this risk is even higher in the monozygotic twin studies. And also we need to set the expectations, because if a patient knows what's going to happen when she's going to get pregnant, what are the challenges she's going to face, she will be more mentally and physically prepared for that. When it comes to contraception, it should be safe. Previously, there was a notion that hormonal contraception can actually cause relapse, but the present data suggests that that doesn't affect or cause relapse, or there are no increased chances of relapse, whatever contraception patient is going to use, but it should be effective, especially if a patient is using a medicine which has more fetotoxic side effects. Talking about the oral disease-modifying therapy. Teriflunomide should never be used in the present era for female of childbearing age. The biggest reason for that is now there are multiple options available. It is very highly fetotoxic. It takes a longer time to get out of the body, so it should not be used in the present time. So there are oral, there are injectable, and then there are infusions. So interferons and glatiramer acetate are the injectables which patient can do herself or himself at home with their own comfort. Then there are oral ones, fumarate, teriflunomide, cladribine, fingolimod, siponimod, ozanimod are in the same group of S1P modulator, receptor modulators. And these are oral ones, and actually not the ones we should use during the pregnancy, and give good washout time to these medications. These medications also should not be used during the postpartum breastfeeding time, and I'll mention the washout time for these patients. Then there are infusions, and ocrelizumab, rituximab, ofatumumab, alemtuzumab, natalizumab are the infusions which can be used. And these are somewhat safer compared to oral medication when it comes to pregnancy and breastfeeding era. Now, talking about the washout time, I have been talking about this again and again. So I had this table for you guys. So looking at the first two, interferon beta, the pointer is not good, but the interferon beta and glatiramer acetate, we don't need to give any washout time. As soon as the patient gets pregnant and the conception is confirmed, you can stop the medicine. Out of these two, glatiramer acetate can be used throughout pregnancy, and this is the only medicine out of all where the FDA recommended you can use it if needed throughout pregnancy. Interferon beta is also safe, but the recommendation is not as strong as the glatiramer acetate. Then there is teriflunomide, is the worst one as we discussed. There should be rapid elimination protocol if a patient is planning to get pregnant because there is a long biological half-life. It could be even more than 1 year patient has to wait. And then we have to check the plasma level of this medication. Then she should plan on getting pregnant. S1P receptor modulator, the pre-label, as per the pharmaceutical label and as per the pharmacodynamic studies, there is a washout time of 2 months. For dimethyl fumarate, again, it's relatively safer out of the oral ones, and we don't need to give washout time. And we will, as soon as patient confirms the pregnancy, we can stop the medicine. Cladribine, washout time per label is 6 months, and per pharmacodynamic, it's 4 months. Alemtuzumab, 4 months per label and per PK and PD. Ocrelizumab, 6 months per label, but the washout time per pharmacokinetic is less because the first 3 months, the placental transfer is not that much. So it is actually safer if we use it in the first trimester, if we really need to. Natalizumab, again, the washout per label is 3 months. There are a few other recommendations with respect to natalizumab, which I can discuss, but we don't need to give any washout per pharmacokinetic. And if we really need to use, we can use this medicine during pregnancy. And the reason for that, the patients who have been on natalizumab and become pregnant and the medicine is stopped, they had 40% chances of relapse. But the worst of all, with those relapse, they have ongoing disability in 10 to 20% cases. So there is a remaining disability which doesn't get better, and that's not nice. So the recommendation is the patients who are on natalizumab, either we stop it and switch to rituximab at least 6 months before the patient gets pregnant. Or the other way around, we can continue with the natalizumab with extended interval of infusion. So rather than 4 weeks, we go from 4 to 6 or 8 weeks infusion in these patients. And lastly, there is a recommendation if we use that protocol and patient had a relapse during pregnancy, we can use glucocorticoid infusions because then you're left with nothing. And these patients are sometimes refractory to glucocorticoid infusion. And in the last recommendation, they mentioned that we should not use it beyond 30 weeks, and we should stop it at 30 weeks in patients who get pregnant. So in the postpartum management, exercise, gradually building up the patient, infant bonding and feeding issues should be discussed and handled. Exclusive breastfeeding, as we discussed, actually helps relapses in multiple sclerosis, so it should be encouraged in patients. Sleep issues and social issues should be addressed because it's a high time for a female, there's a life change, and they need adjustment, so they need a lot of support. And finally, if patient has a relapse or there are increased chances of relapse or you're suspecting the disease is progressing fast, you can do a postpartum MRI or MRI during pregnancy. It's safe to do an MRI during pregnancy, but gadolinium should not be used during pregnancy exclusively. It can be used in the breastfeeding time because the excretion in the milk is small, but it still is there. So recommendation is, if really needed, you can do it, but otherwise avoid gadolinium. Then how you're going to assess this scan is different from the previous scan, but comparing it. And that's where we are lacking in Pakistan, because a patient goes to get an MRI in one institution, then goes to another institution to get the second MRI, and the radiologist, they don't compare, and the whole ball is dropped. When it comes to breastfeeding, there are certain ways to handle that as well. So exclusive breastfeeding for the 6 months, And then we can start a medicine which has a rapid onset of action, and monoclonal antibodies are good medicine for that time with a short therapeutic lag. So patient is quickly weaned from the feeding and then switch to the medicine, so the excretion is less and secretion is less in the milk, and baby is safe. Or use a medicine which is not secreted in the breast milk, and we discussed already that the medicine which are not are the ones glatiramer acetate and interferon. I'm going to give you some more update as well. And still, if a patient is very cautious and she doesn't want to use any medicine, she's a high-risk patient, we can start monthly glucocorticoid infusion to save these patients from relapses. So this is the table I was talking about. So glatiramer acetate is unlikely to be secreted in the milk. There is a transluminal transfer, but it is compatible with lactation. Interferon beta, again, very low amount in the milk, and it's also compatible with lactation. Natalizumab, again, recommendation is if really needed, but these babies tend to have infection and impair response to vaccination. Same goes for ocrelizumab. The data is not available yet, but it's because it's a kind of a similar medicine to other monoclonal antibody. So there could be increased chances of infection in the baby and impaired response to vaccination, and it is can be used during lactation with caution. Dimethyl fumarate, again for the oral ones, S1P modulator, teriflunomide, cladribine. The data is not available because all these medications are highly fetotoxic. So animal data has given us the way. There is no no human data. But there is high transluminal transfer, there are increased chances of infection and side effects, so these are not recommended during the lactation period. This is something Dr. Suhaib has talked about, and I will reiterate it, but how we get the data, because for glatiramer acetate, 4,000 exposed pregnancies and still no problem came up. So that's why we consider this medicine relatively safe during pregnancy. Interferon beta, again, 1,200 exposed pregnancies and not much in terms of pregnancy-related complications. So it's also considered to be safe during the pregnancy and breastfeeding. Rituximab, because these are from the same class medicines, so there are 400 exposed pregnancies, and there are some side effects, especially in terms of lymphopenia, infection, have been noted in the patients, but not too much. So there is a recommendation. Previously, the recommendation was strong, but the recommendation is there that it can be used, especially in patients who are having active disease in the pre-pregnancy phase. Now, talking about the case, I said I'm going to ask some questions so to keep everyone up. So the extended disability scale for that patient was 2 when she presented to us first time. Because of the weakness, she was having some depression. So I'm not going to go into the details of the scale. We do it. And it's a research scale. It really helps when you are trying to do some research. That's why I just see 10 patients a day, because I do what it really takes to do in my patients. So she got the first Ocrevus infusion in the June of 21. The second infusion was delayed because she got COVID, but thank goodness she was fine. And it was delayed, and she got the second infusion a little later in July. Then she got married in November of 2021. And I was very graciously invited to her marriage as well. Then she received her last infusion this year in January. And she is still not pregnant but trying. But remember, from the day one, even when she was not married, we discussed about marriage. My MOs are over here, they can confirm it for you. We discussed about childbirth. We discussed about the issues around marriage and childbirth. We discussed about anxiety and depression every visit. So I take at least 45 minutes to 1 hour to see a patient. Her question was that should I get the next infusion or not? I'm already trying. And the answer to that question was, and I gave her that answer yesterday, she can. I agree with you, she can, but before that we have to confirm her pregnancy status. So that was the answer. It seems small, but I can tell you many times it happens that you do the medication and then realize, oh, this patient could be pregnant. but now the arrow is already fired. You cannot get it back. So recommendations. So there is a trend in recent time towards using anti-CD20 therapy for clinical stability, and this is with respect to the patients who are having highly active disease, okay, during pregnancy, before pregnancy to stabilize it, and if really needed, you can use it during pregnancy with caution and in the breastfeeding time. Contraception or fertility discussion should be done during each clinic visit. Avoid teriflunomide even in males as well, because it's secreted in the semen and there are increased chances of problems during the pregnancy and with the baby. We should develop local pregnancy registry. I have already discussed with my patient about this thing. I'm not sure if it's gonna happen or not. And I will also recommend, I have discussed with Roche representatives today as well, that we should have other medications available in the market. You must have heard me talking again and again about glatiramer acetate. It's safe, it's cheap, it should be available in our market. Thank you very much, and I'm happy to take any questions.